Welcome to AMSECT 2026. My name is Giles Peake. I'm an ECMologist and congenital heart surgeon at the University of Florida in Gainesville. And my talk today is about the pump-controlled retrograde trial off. These are my disclosures. Of course, the main disclosure is that ECMO is a team game and that the patient is always at the centre of our efforts. There have been many advances in ECMO circuit and cannula technology over my 32 years of ECMO practice, and we now have much more efficient and reliable hardware, which is easier to operate and causes less host response in the patient. I think that this translates into better patient outcomes, or put another way, the ability to support patients who in the past may have been considered contraindicated. We should not lose sight of our initial aim of supporting tissue oxygen delivery, as we can see here shown on the near infrared. We should also be mindful of this aphorism from the Stoic philosopher Epictetus, which continues to guide us nearly 2,000 years later. I'm going to take you back into neonatal ECMO history now so that we can understand how Bob Bartlett and Al Gazzaniga started with Esperanza on VA ECMO in 1975 at UC Irvine. Neonatologists were aghast at the carotid ligation, but I can attest, having met her several times, that she is a normal 49-year-old with her ligated carotid, the oldest such patient to date. Bob Bartlett himself was also concerned about the need to ligate the carotid, I believe mainly because of the way it's perceived rather than the actual risk of the procedure. And so he tasked ECMO fellow Jay Zwischenberger, seen here with his collaborator Dongfang Wang, to develop the vena-venous double lumen cannula. This was a significant step forward as it allowed the carotid and jugular to be preserved. But there was a fair but manageable amount of recirculation with the original right atrial design. So here you can see the semi-Seldinger technique in use. This was our technique of choice at the University of Leicester in the pre-ultrasound era, and it remains equally relevant today. It gives an excellent cosmetic result, it's fast and reliable, and allows decannulation with a simple U-stitch in the skin. The significant but manageable recirculation with the original right atrial designs prompted Dongfang Wang and J.B. Zwischenberger to develop the bicaval design, which you can see here. This was fantastic, except for newborns, who seemed to develop a 7% index of late cardiac tamponade, as we can see here in this publication in Perfusion of our early experience with the cannula at the University of Leicester. It was not clear why this developed, but you can see here 73 patients with a 7% late tamponade development, and it did not seem to be associated with any kind of difficulty in cannulation. This prompted a switch back to vena arterial ECMO for respiratory failure, as there were no longer widely available VV double lumen cannulas, and multi-site VV was not yet accepted in newborns. This in turn led to a much more involved trial-off process for these patients who are now on VA instead of VV. This upset Chris Harvey, Chief ECMO Fellow at the University of Leicester. He is now the director. And you can see here how much I trust Chris as he's holding my ropes. So this slide contrasts the technique for trialling off VV versus VA, and you can see how much more convoluted the VA process is. In fact, the VV process is so straightforward, we can even allow patients to trial themselves off. You're right there. Good girl. That's it. So what does that mean, Morgan? Exactly. So apart from the amount of work for the ECMO team, the traditional clamp trial necessitated the presence of a bridge, which was not needed otherwise, It had an incidence of cannula clotting. It was associated with swings in blood pressure during unclamping and also mandated anticoagulation. All of these issues prompted Chris Harvey to innovate the pump-controlled retrograde trial off. The hydrodynamic principle of the pump-controlled retrograde trial off is shown here, allowing my younger and cooler self to surf this standing wave in Bourg Saint-Maurice, moving upstream at the same speed as the water moves downstream, and thereby remaining stationary in relation to the riverbank. We achieved this by reducing the RPM until the forward impetus of the centrifugal pump exactly matches the impetus of the heart, pumping blood back up the carotid cannula. We then reduced the RPM further, allowing a controlled AV shunt to develop, typically around 30 mils per kilo. Let's examine a clinical case in this video tutorial, which is published in the Multimedia Journal of CT Surgery by Stukov et al.
Dilated right ventricle and moderately to severe mitral regurgitation. The patient experienced cardiac arrest after some rhythm issues, and she was emergently cannulated for VA ECMO within a few minutes of ROSC. Subsequently, she received an atrial septostomy. Over the course of a few weeks, her left ventricular function improved, and we proceeded with low-flow ECMO trials. 5 days later, her EF improved to 53% with mild mitral regurgitation. Therefore, the decision was made to proceed with a pump-controlled retrograde trial of ECMO. Prior to starting pump-controlled retrograde trial of, the briefing is crucial to ensure the team is ready for the procedure. Before weaning the patient from ECMO support, the ventilating parameters are adjusted for adequate gas exchange according to the arterial blood gas. Inotropic support adjusted to the desired maps. Centrifugal pump allows backward flow from the patient. When the arterial blood pressure overcomes the resistance of the circuit, the blood flow will be circulating retrogradely. Pump control retrograde trial off is achieved by reducing RPMs in a controlled manner until you reach zero flow. This method of weaning from VA ECMO creates a partial arteriovenous shunt. This graphic illustrates normal flow pattern. The flow probe is switched with direction towards the pump head, and the counterforce RPMs are lowered more until the retrograde flow is achieved. This illustration shows the flow pattern and direction of the flow probe. The sweep gas is discontinued. The counterforce RPMs are lowered even more, and the retrograde flow is achieved. In this patient, 30 milliliters per kilogram per minute was sufficient for the trial off. It is worth to notice the color change in venous limb of the circuit, as some of the arterial blood is now shunted to the right atrium. Hemodynamic parameters are closely monitored during pump control retrograde trial off. Cerebral perfusion is monitored with NIRS. Organ perfusion is evaluated by urine output, serum pH, and lactate level. The first gas sample is drawn at 15 minutes of pump control retrograde trial off and every other 15 minutes during the 1-hour trial. Echocardiography is performed at 30 minutes of trial. Potassium, ionized calcium, and hematocrit values are corrected as needed. Once weaning trial is considered successful, the team can proceed with the clamping of circuit. The cannulas are clamped and left in place until the next day after trial. This preserves vascular access in borderline patients, and the patient can be connected to the ECMO pump in an emergency setting if needed. To disconnect the circuit from the patient, one will need a standard ECMO instruments tray. The cannulas are prepped and draped in a sterile fashion. The cannulas are clamped distally and a primed quarter-inch deadhead connector introduced to the venous cannula. The cannula was flushed clear with heparinized saline, and the arterial cannula is connected and flushed similarly. To avoid thromboembolic events, continuous infusion of heparin at a rate of 3 ml per hour to each cannula is continued until surgical decannulation. Infusion lines should be connected to the side ports of dead enders in an airless fashion, and the bivalirudin infusion is continued. Final echocardiography demonstrates excellent biventricular function post-decannulation.
So there you have it, a straightforward technique that can be achieved in patients who are not anticoagulated, although we would not leave the cannulas in place in a patient that was not anticoagulated. And this makes trialing off extremely simple, very straightforward, and reduces the risk of clot formation. There's a lot of concern about clots being washed out of the membrane back into the patient up the venous line, but I've not seen this happen in clinical practice. There's also concern that the patient might not tolerate the trial off. But if you think about it, that's the whole process of the whole reason of doing a trial off in the first place is to ensure that the patient's ready to be decannulated. So actually making the heart pump more than one cardiac output for a short period of time gives you a mini stress test to see whether they'll tolerate coming off. We would typically run the retrograde trial off for an hour and then make a decision and either go back on or dead end the cannulas. So I'd like to finish by directing you towards some resources produced by ELSO. The Neonatal and Pediatric ECMO Foundations course does actually have instructions for pump-controlled retrograde trial off alongside the classic technique and also the ECMO Specialist Training Manual, the Blue Book, and the 6th edition of the Red Book. I'd also like to draw your attention to the ECMO Bedside Guide, which is a fantastic resource which is free and downloadable from the App Store, either in Apple or Android, and contains lots of useful ECMO information. So I'd like to finish by thinking about my friend and mentor, Dr. Bob Bartlett, who, as you know, has now sadly left us and is sorely missed. And he showed us how to do ECMO and infused every single one of us. And I'd like to think about this message that he wrote on the wall of his lab before he died. And it says, 10 years from now, grateful patients will be alive because of the research we're doing. They won't know how or why it happened without complications, but you will. Thank you very much.